Hello, everyone. It's really nice to be here on behalf of the Health Resources and Services Administration and to share some of our perspectives in the development and the implementation of the pregnancy weight gain guidelines. You've heard us speak of HRSA, and thank you for clarifying that it is the Health Resources and Services Administration, and it's the primary federal agency for improving access to health care services for people who are uninsured, isolated, or medically vulnerable. While the agency has 6 bureaus and 10 offices, there are really 2 of the bureaus that particularly have relevance to the work of this committee and the implementation of the 2009 Pregnancy Weight Gain Guidelines. And that is the Maternal and Child Health Bureau, which, as you heard, I work for the Bureau. Dr. Liu, whom you heard earlier, is our Associate Administrator, and then also the Bureau of Primary Health Care. And here you see the 2 mission statements, and what you'll particularly note in looking at them, while there is overlap, the Maternal and Child Health Bureau is primarily focused on the delivery of core public health services. The Bureau of Primary Health Care, which oversees community health centers, is more focused on the delivery of primary care. And today I'm going to try to spend some time really highlighting the opportunities within programs within these 2 bureaus where the implementation of the 2009 guidelines, I think, can really move forward. The federal MCH program has a long-standing history and involvement in maternal nutrition and perinatal health. And this history actually includes the funding, the provision of funding support to the Institute of Medicine for development of nutrition reports that date back as far as 1970s. Today, specifically programs within the Maternal and Child Health Bureau that I'd like to highlight are the state Title V MCH Block Grants, the Healthy Start Grants, the 2 initiatives, one of which you've already heard, and that one is the State Collaborative Improvement and Innovation Network to reduce infant mortality, and the other is the National Maternal Health Initiative. 2 programs within the Bureau of Primary Health Care that I'm going to highlight are really the Health Center program and then their efforts around health information technology. The biggest investment for the Bureau is the Title V MCH Block Grant Program, authorized under Title V of the Social Security Act. And the state grants are Formula Block Grants to states. They're awarded annually, partially based on the number of children in poverty within a state as compared to the number of children in poverty nationally. Over the years, the national and state leadership provided by Title V supported programs has made contributions in moving forward the implementation of recommended standards for prenatal care and for improved nutrition care practices during pregnancy. I will say there is growing interest and investment among the states in applying the life course perspective to MCH practice. The block grants support a range of services in the states to ensure the health of the nation's mothers, infants, children, including children with special health care needs and their families. And just to give you some sense of the reach of these programs, in fiscal year 2011, the 59 states and jurisdictions served more than 44 million individuals, which includes more than 2.3 million pregnant women. In addition to national performance measures and indicators that states report annually on, states also have to develop between 7 and 10 state performance measures. And when you look at the current state performance measures, you will see that 26 of them specifically focus on weight status of women before, during, and after pregnancy. Some choose to focus on weight status in women of reproductive age, be it normal healthy weight or overweight obesity. Some are more focused on the pre-pregnancy body mass index in women who have given birth. And then some states, such as North Carolina, are focused on appropriate weight gain during pregnancy. Just to give you some additional examples of state Title V program activities, California considers obesity in their risk factor analysis for pregnancy-associated mortality reviews. They monitor the pre-pregnant weight status and the pregnancy weight gain based on the revised IOM guidelines. In South Dakota, they're implementing a gestational weight gain during pregnancy initiative that provides educational materials, toolkits on adequate pregnancy weight gain to all physicians attending births in South Dakota. Virginia, through a partnership with the University of Virginia, has launched the Pregnancy Weight Gain Guidelines continuing education modules. Kentucky Department of Health provides annual training to local health department nurses and staff, and included among this is pregnancy weight gain according to IOM standards. And then Wyoming, through their Healthy Babies Worth the Wait, is really a little more focused on gaining enough weight during pregnancy. Moving to the Healthy Start program, this program was initiated in 1991. It provides grants to community with very high rates of infant mortality, at least 1.5 times the national average. The program focuses on contributing factors which influence perinatal trends in high-risk communities. These projects are community-driven, they're service-focused. Again, just to highlight the reach of some of these programs, in 2010, there were 104 Healthy Start projects, and they were providing services in 38 states, the District of Columbia, and Puerto Rico. They do provide risk reduction, risk prevention counseling on a range of issues. Prenatal program participants receive counseling around overweight, obesity, underweight, gestational diabetes, and interconceptional women participants also receive counseling, again, around overweight, obesity, underweight, lack of physical activity, and diabetes. To share with you an exciting new initiative within the Bureau is the Collaborative Improvement and Innovation Network, which is COIN, to reduce infant mortality. And it was born out of the January 2012 Infant Mortality Summit that was convened in the 13 southern states. It was initiated in March 2012 as a mechanism to support the adoption of collaborative learning and quality improvement principles and practices directed at reducing infant mortality and improving birth outcomes. It's a partnership effort. It states at their Infant Mortality Summit expressed the need to really have common evidence-based strategies for reducing infant mortality, as well as the opportunity for shared collaborative learning and action across the states. So convened early last summer, strategy teams were put together. They've been working collaboratively. Most of them should finish up their work by the end of this year. And they've come together to identify common priority areas which were identified out of the individual state infant mortality action plans. Here you see the 5 strategy teams in the areas they're addressing. A particular interest to this committee may be number 2 is expanding interconception care and Medicaid. The strategy teams have established quality improvement aims and identified state-level opportunities for achieving their aims, and they're currently developing measurements for tracking their progress. I have to say the COIN is part of a larger portfolio of efforts to improve birth outcomes, and it contributes to the advancement of Secretary Sebelius's national strategy for addressing infant mortality. It promotes increased sharing of best practices across the states, and it's strengthening the existing collaborations between states in addressing MCH issues of mutual concern. It is going to be expanded. We're having an infant mortality summit in Region 5 later this month. I'm not going to spend much time on the National Maternal Health Initiative because I think you heard from Dr. Liu and Dr. Conry this morning. This effort, it's just getting underway, a public partnership effort. Here you see the work groups that have been formed, and recommendations will be forthcoming from the work groups and the efforts to be launched in May. Thanks to the Healthy Center program, just to share with you a little bit of information about our Health Center program, which has obviously a very wide reach, reaches over 20.2 million patients in calendar year 2011. There were 80 million patient visits, over 138,000 staff. If you look at the demographics of the female patients that they are serving, you can see that slightly over 50% are between the ages of 24 and 39. Race ethnicity breakdowns, 41% are white, non-Hispanic, 31% Hispanic, and 21% Black, non-Hispanic. The health centers report in their uniform data system on specific core measures. There are no measures around pregnancy weight gain. However, a few that are somewhat related are the percentage of early entry into prenatal care and the percentage of newborns below normal birth weight. This is somewhat of a busy slide, but I think you heard Dr. Liu talk about it a little bit this morning, the culture of quality improvement that exists within HRSA. And within the Bureau of Primary Health Care, their quality improvement strategies include the development and enhancement of access points to really transform healthcare, particularly around the adoption and meaningful use of electronic health records and the implementation of patient-centered medical home, to integrate the health center programs into the other community services, as well as to align these services to promote quality health care. You can see here the priorities and goals. I think particularly 2 and 3 are areas where there are really potential opportunities for moving forward on the implementation of the pregnancy weight gain guidelines. Again, there are no measures around gestational weight gain, but there are measures around the screening of body mass index and follow-up, and this is one area where there are opportunities to really, by focusing on the follow-up, the screening, the counseling related to body mass index, it gives health centers the opportunity to follow the woman across her lifespan, including during pregnancy. Also, clinical decision support is one way to really maybe enhance guidelines-based care. And, you know, there can be triggers put in that are based on patient characteristics, timing of the visits. In addition, just to talk about the electronic health record and the opportunities it presents, you know, through its automation, it's very easy to really track the implementation of guidelines-based care, you know, were the guidelines discussed, and then to track whether tied into performance and follow-up. Also, future opportunities around patient-centered medical home. And as you know, patient-centered medical home is accessible, it's comprehensive, it's patient-centered, and it's delivered by a team of interdisciplinary providers. And also the measurement and improving performance through systems-based approach. And just before I get to, these are my closing slides, but I would like to highlight sort of what Marta said too. All of this is enhanced through really working together and in partnership, and in the community health centers working with the Title V programs, working with the WIC programs. So, you know, there have been some efforts in this area, but certainly a need for more. So just in closing, to share with you some of HRSA's perspectives, and I think you heard some of these this morning in Dr. Liu's presentation. There are opportunities in HRSA programs to reach key audiences in promoting the adoption of the guidelines among providers and in educating women regarding their importance. Broad dissemination of the guidelines is considered essential to HRSA's efforts to inform women, healthcare providers, our state Title V programs, our community health agencies, and others about the importance of entering pregnancy within a normal body mass index and achieving recommended weight gain during pregnancy. Our focus really goes beyond just gestational weight gain. It really includes the promotion of appropriate weight for women before, during, and after pregnancy. Preconception counseling, and I would add interconception counseling to that as well, on the importance of entering pregnancy within a normal body mass index range. Full implementation of the revised pregnancy weight gain guidelines are considered to be important changes in the care that we provide to women. And I will say these changes we consider to be really important to improve and to promote optimal health outcomes for both mother and child. And lastly, continued research is needed on effective interventions for promoting healthy weight in women before and after pregnancy and for achieving weight gain during pregnancy that is within the recommended ranges. So, thank you.
Thank you, Michelle. And the third speaker for this session is Suzanne Phelan. She's an associate professor of kinesiology at Cal Polytech, and she's an adjunct associate professor of psychiatry and human behavior at Brown Medical School. Her research interest is in applying behavioral methods to prevent and treat obesity. She's also conducting research on lifestyle interventions to prevent pregnancy-associated weight retention and obesity. Has several publications and numerous professional presentations in the area of obesity. Suzanne?